Okay. Let me see. Okay, so we'll go ahead and get started. So my name is Emily Gilkes. I'm a second year resident here at U of L. So my presentation is on the stigmatization of paraphilic disorders and sexual offending related conditions and the clinical implications for a practicing psychiatrist. So I know that this topic may sound a little bit niche, but I do think that the implications are broad and really touch every area of psychiatry. So to start with some of the objectives, so first we'll discuss the history of paraphilic disorder and sexual deviance in the DSM. We'll move on to paraphilic disorders versus paraphilic interest or paraphilias, paraphilic disorders versus pedophilic OCD, just so we have got a good background before we jump into the article, which is the stigmatization. And then we'll just wrap up with how this is applicable to us as psychiatrists. So, going a little bit into the history of paraphilic disorder. So, paraphilias in the DSM-1 were not explicitly named. They were more broadly characterized under sexual deviations and even included things such as homosexuality, which is not included now. And then additionally, it was very much based off of strong moral and psychoanalytical overtones. Once we moved to DSM-2, it still continued under the sexual deviations again. But this time, some of the descriptions reflected more of the Freudian theory and societal norms rather than clinical evidence. When we hit the DSM-3 in 1980, that's first when the term paraphilia was introduced. So at that point, too, homosexuality was removed from the DSM, rightfully so, and they again named paraphilias, and they included different paraphilias, including exhibitionism, pedophilia, sexual masochism, and things of that nature. And we'll go more into those. And DSM-4 still retained the same name. Paraphilia list stayed the same. The criteria was slightly refined, and they really wanted to emphasize the distress and impairment that this disorder does cause. So more careful distinction between paraphilic interests and unusual interests versus disordered behavior, which again, we'll get to in a bit. And then the big um, conceptual shift was with DSM-5, so our most recent one. This is where the terms paraphilic disorders were introduced in order to distinguish between, the disorders and then the paraphilic interest, people having non-pathological atypical interests. So key distinction is, paraphilia needing to cause extreme distress and impairment in order to be considered a disorder. So on this next slide, so a little bit more into paraphilic disorder versus paraphilic interest. So I think in general, there's a great deal of controversy concerning paraphilia and defining what normal versus deviant or disordered behavior is. And I think that some of this is also dependent on cultural views and cultural views of acceptability. Even going back to the previous slide with, homosexuality being listed in the DSM, and now no longer being in the DSM. So I do think it is something that is kind of maybe forever changing, but I think we can all agree that certain paraphilic disorders such as pedophilia will probably remain. So the criteria I've got listed here, so those reoccurrent, intense, sexually arousing fantasies, sexual urges, or behaviors generally involving one of the three. So non-human objects, the suffering or humiliation of oneself or one's partner, and children or other non-consenting persons that occurs over at least a 6-month period. So again, emphasis on the extreme personal distress about their interest. So they, do have this sexual interest, however, they do not want to have this interest. They are mostly disgusted by it, some individuals. And Sorry, I just skipped through here. Okay. Um, so that is the biggest distinguishing factor between an actual disorder and the paraphilic interest. Because somebody could, be listed as a pedophile or having assaulted children in the past, but not necessarily be considered paraphilic disorder if they're not having that accompanying stress, and it's more than just that fear of society's judgment. Okay. So here is some of the different paraphilic disorders. So just running through a few of them. So it's F65 code. They different codes. So first one being voyeuristic, observing and uninspecting naked person, disrobing or engaging in sex. Exhibitionism, so exposure of one's genitals to an unsuspecting stranger. Sexual masochism, deriving sexual excitement from being humiliated, beaten, bound, or otherwise made to suffer. On the flip side, sexual sadism, urges and fantasies of acts in which psychological or physical suffering of the victim is sexually arousing to them. And then pedophilia, which is, with sexual interest in children. And then a few others that they have listed as well, but don't touch on as much in the DSM. Things like necrophilia, zoophilia, urophilia, and so on. So I think an important distinction to make too, and something that I actually didn't really realize was as prominent until I started in my therapy clinic. This came up a surprising amount in some of my therapy patients, especially those with already pre-existing anxiety or sexual assault histories. So pedophilic obsessive compulsive disorder. So this is a subtype of OCD where individuals experience recurrent, unwanted, and distressing thoughts about harming or being sexually attracted to children. So these thoughts are ego dystonic. They do not align with the person's values, desires, identity, and it can cause them pretty intense guilt, shame, anxiety. And the important distinguishing factor between the pedophilic obsessive compulsive disorder and paraphilic disorder is in the OCD is there is no associated sexual interest. They are very afraid that they may have one, but they do not. There's, none of that that's going on. It's just like the fear of people thinking that they might be. And typically these obsessions, thoughts, are followed by compulsions in order to neutralize the thoughts. So whether that's mental rituals, reassurance seeking, or even avoiding kids or social media. These individuals usually do a lot of excessive questioning of their morality and past behaviors. And again, importantly, these individuals are not at an increased risk of offending. These thoughts are feared, not desired, stressing. And then this is in one of the articles. I, again, did not realize how prevalent this was. And I think that it does go along with this presentation and that stigmatization of people being afraid to come forward with such distressing thoughts, out of fear that they may be judged or may face some sort of consequences. But they did a study here questioning those who do have OCD, and it was about 15% of people. It was a study of about, I think it was 1,000 people. 15% of them had endorsed having those OCD pedophilic thoughts and that intense fear that they may be a pedophile without having any actual sexual interest or anything to prove that. So here are just some quotes I pulled that are going over, different physicians' opinions about paraphilic disorder and paraphilias being in the DSM. So, for example, one of individuals said sexual preference for a 14-year-old is a mental disorder. You can't be serious. They're just criminals with excuses. Another individual said the important thing for us was distinguishing between benign paraphilias versus paraphilic disorders that cause real anguish to the individual or predispose the individual to violate the rights of other people or harm them in serious ways. So So you can see this is a very controversial topic. So with that said, we will now get to my article. So again, the article is Stigmatization of Paraphilias and Psychological Conditions Linked to Sexual Offending. So this was originally published in the Journal of Sex Research in April of 2020. I actually came across the article after looking through the Journal of American Academy of Psychiatry and Law. Um, this journal was referenced numerous times throughout several different articles. And yeah, so I thought it would be something interesting and a little different. The study was conducted in Germany through their medical school and psychology department, as well as some other partnering um, professionals in the area. So with the study, or with the article, there's two different studies that they had completed. So the first study actually kind of sparked them moving on with the second study. So I'll start with the first one. So this paper really sheds light on how public perceptions of certain psychological conditions, especially paraphilic disorders, can influence patient care across all psychiatric settings. Um, you know, as we'll talk about, there's an intense fear of people coming forward with these distressing thoughts because of the fear of judgment. So this first study, the goal was to replicate prior studies done, one in 2015 by Dr. Gilkes. So they based their study off that one. So this is a little bit bigger of a study. So goal was to replicate that study by comparing public stigma towards three psychological conditions. So what they did is they used a Likert scale, so ranging from 0 to 6, being like do not agree at all to very much agree or completely agree. And they conducted the study by enrolling 720 participants. About a third of them were university students. A third of them were somehow associated with the students or other individuals at the university. And then the last third was individuals within the community in Berlin, Germany. And then 58% of the participants were female as well. So again, going back to that Likert scale, so what they focused on was 4 stigma scales. So controllability, dangerousness, effective reactions, and social distance. So controllability being how much control does this person have over their behavior. Dangerousness is the perceived threat to children, adolescents, and adults. Effective reactions being levels of fear, anger, and pity. And then last, the willingness to either interact, hire, or befriend these individuals. And they looked between pedophilia, sexual sadism, and antisocial tendencies. So a little bit of the summary of the data that they got was, I think, not super surprising. People with pedophilia received more negative reactions than those with sexual sadism or antisocial traits. Pedophilia got the most negative reactions overall, especially in perceived danger to children, which is understandable. Feelings of anger, desire for distance, people not wanting to be their friends, not wanting to be their colleague or neighbor. And interestingly, all of them scored about the same in the level of controllability, like how were these individuals able to control these sexual desires or not. And all of these results were statistically significant. And I think another important thing to note is in these vignettes that were described to the people who were in this study, all of the individuals were described as non-offending, had never had any sort of criminal record. So I think that's important to note too. And then over here, on the slide, you can just see a little bit more of the different variations in how people feel towards pedophilia, sadism, and then those antisocial tendencies. So because they ended up getting much stronger results than they thought for pedophilia. They had hypothesized that people would be equally as, angry, wanting to social distance across all fields. So they wanted to take this study an extra step further. So in addition to pedophilia, they wanted to add in two other more rare but kind of maybe jarring paraphilic disorders. So necrophilia and zoophilia. So necrophilia being sexual interest in corpses, and then zoophilia being sexual interest in animals. So for this study, they had a new set of participants. They did the same exact Likert scale with the same controllability scale, dangerousness, effective reactions, and then the social distance. These participants, based on the perceived dangerousness, about 90% of people believed that those with pedophilia were dangerous to children. Again, all of these individuals in these vignettes were described as non-offending. So 90% believed that those with pedophilic disorder were dangerous to children, in contrast to only 25% for necrophilia and 15% with zoophilia, which was a little bit surprising to me. In terms of controllability, there was not a statistically significant difference. Most of them say about around 16% of these individuals had actually decided to choose to have these sexual interests, but the overwhelming majority agrees that they do not have control over these interests. The next being the effective reactions. So anger was most strongly directed at people with pedophilia, with about 70% in agreement, followed by zoophilia, which was 46%, and then necrophilia, which was 25%. Fears and social distance were also higher in people with pedophilic disorder, and pity was not statistically significant among the different groups. There was a low level of pity, and it was about the same among all groups. And lastly, the social distancing. So while people felt that they didn't wanted to social distance, not wanting to be friends, not wanting to be neighbors, or not wanting to have a coworker with any of these paraphilic disorders, highest was for pedophilia. However, the highest belief that these individuals need to be incarcerated was actually those with necrophilia. So I was expecting people to say pedophilia since there was such strong reactions, but people did agree that those with necrophilia, even those who have never acted on these or had any sort of criminal record, individuals believed that because they do have this paraphilic interest, they should be in jail. So how is this, how does this impact us? Why is this important for us? I think that even in outpatient and general psych settings, we'll encounter patients with intrusive sexual thoughts or taboo ideas. Like I had mentioned before with the pedophilic OCD, that was something that I was never really aware of that was that prominent. And in my therapy clinic, I have two patients that expressed that, and they had extreme distress about it. Again, not paraphilic disorder, separate thing, but still prominent. So I think what is essential for us to learn is knowing how to respond in these sort of situations when an individual does disclose this. There's an intense fear of stigma, which I think a lot of times ends up preventing disclosure. And patients with paraphilic disorder, especially those who are non-offending, often do not disclose because of the fear of being labeled, hospitalized, or even reported. Another thing to consider is the risk of misdiagnosis. So, for example, a person with pedophilic OCD, they have these ego-dystonic intrusive thoughts, and they don't actually have that accompanying sexual interest. They may be mistaken for having pedophilic disorder. And if we don't understand the contents and ask these nuanced questions, there can be a lot of that misdiagnosis. I think also therapeutic alliance is pretty fragile. Humans, people are hypersensitive to disgust and judgment. Nonverbal cues, tone, and clinician discomfort can really lead to dissolvement of that therapeutic alliance. We also have to consider if we over pathologize or act on implicit bias, then we may unintentionally harm vulnerable patients. And so these patients, again, we will see them in all of different settings. So I think it is important for us to know this. And these sort of paraphilic disorders may even be underlying to different presentations that we see, such as suicidality or self-injury, depression, or substance use, in order to get rid of these or numb out these different paraphilic disorders. So, what can clinicians do? So I think again, important is maintaining neutrality when discussing these topics or investigating further, being able to differentiate between thought content, behavior, and intention, asking those non-judgmental clarifying questions such as, are these thoughts distressing or unwanted? Have you ever acted on them before? And then reinforcing safety and disclosure, and being able to understand how stigma shapes our clinical reactions and how we can prevent any sort of re-traumatization in vulnerable populations. So one of the studies that I referenced a lot and that I was going to do my article on, but I felt like there was too much variation, is there are several different studies that had been done about the intervention of psychiatric medications or psychotherapy in individuals with paraphilic disorders. Several studies analyzed groups of people who have either offended before and act on these paraphilic disorders, um, along with those that have not. And they ended up doing 4 different groups, and half of them ended up seeking psychiatric care, starting medications, most oftenly SSRIs or luteinizing hormones. And then the other group did not engage in any sort of psychiatric or therapeutic treatment. And they ended up finding that there was about a 70% reduction in those who had previously offended, 70% reduction in them offending again. And then there was a 60% reduction in individuals from offending at all. And again, I have found several different studies with different numbers, but I will say that most of them are around that area. So it can be a pretty significant difference and somewhere that we can intervene as psychiatrists to, protect other individuals in our community. And I think this is why it's important, not only just in the topic of forensic psychiatry, but all psychiatrists. I'm sure we all in, EPS and on the psychiatric unit have had patients that have histories of, sexual assault, them being the aggressors, or have been listed as pedophiles. And, this could be our opportunity in order to see how we can prevent them from acting on those urges, how we can help with some of that distress, and how we can overall, make the community safer. So I think, implementing some of this ethical and trauma-informed care, and just really knowing that we can make a difference in some of these disorders, can be really helpful to our patients. And that is my presentation. Here are my references. And I am open to any questions.
Thank you so much, Dr. Gilkes. Great topic. And so, yeah, if anyone has any questions, please put them in the chat or Q&A, or if you'd like to raise your hand to speak directly, that works too.
All right, I'm unmuted. Cool.
Oh, you're good now.
All right, yeah, really great talk. For the students in particular, as far as OCD questions goes, this is the question that they ask. They ask about somebody who's having intrusive thoughts about wanting to have sex with children or wanting to have sex with animals, but they don't want to do it. They don't ask the question about, always washing their hands or turning on and off the light. So that's really helpful for you to have in your slides there. I noticed that when it was talking about that, it was speaking specifically about pedophilic disorders. When we see patients, a lot of times it seems like this stigma kind of goes across the board, not just with those prepubescent children, but like a hebephilia or ephebophilia. Everyone kind of lumps them together, and it's really hard in EPS sometimes. We have patients who have been accused of things like this or on sex offender registries to get them placed into psychiatric hospitals if they have like concurrent conditions with that past history. And it's really a stigma that I think is really hurtful in terms of this person getting better and not offending again. And so I think it's really helpful that you had this talk today and appreciate it.
Thank you so much. And then I think Hope has a question.
Hi, it's
Medical
me. I'm
student.
undercover.
Oh,
Sorry.
okay.
It's me. It's me. Awesome talk. Loved it. Loved everything about it. I was wondering, I know this wasn't necessarily within the purview of the actual paper itself, but I know there's a lot of discussion of people that underwent sexual abuse as children, sometimes mirroring or performing those behaviors either as children. But I was wondering more so if there was anything in these papers that talked about what kind of what proportion of these paraphilias develop spontaneously versus are related to either early childhood experiences or just kind of what your opinion is about that if it wasn't explicit.
Yeah, so it wasn't explicitly stated in my article, but in my research, it was very prevalent. A lot of it, articles that I found were comparing or going over the adverse childhood experiences, so the ACE scores, and how, a history of trauma, abuse as a child can predispose individuals to having paraphilic disorders. But I didn't find any studies that showed, the difference between how prominent it is among those who have been traumatized in the past versus, spontaneous. So I think that would be a really interesting place to do some more research, or I can get back to you on that.
Thanks. I'm sorry to be like, hey, where's this thing that wasn't actually covered? But I think that it's interesting in terms of informing how we work with those people, where that came from. So, but really, really interesting talk. Thank you so much.
All right, any other questions for Dr. Gilkes? And if not, we can get, transitioned here to our next speaker. Thank you for the audience participation.
Hello, everyone. Thanks for joining in for this journal club. I am Aditya Shah. I'm a second year resident as well. I'm going to talk about the prevention of delirium in patients on medical and surgical units using Belsomra, Limborexant, and Remotion. Um, Okay. So this is a brief overview of my journal club. We're first going to talk a little bit about sleep physiology and its relationship with delirium itself. And then we are going to go through the article, talk about its objectives and methodology. And then ultimately, we're going to discuss some of the real world implications of what we learned from the article. So talking about sleep physiology, but why do we need to talk about that? It's because almost 50% of hospitalized patients have insomnia. That's an impressive number. These patients on an average sleep only or 1.5 hours less than what they would at home. And we all know the factors involved in that. There are environmental, excessive light at bedtime, or excessive noise during the entire day, physical discomfort, psychological factors like anxiety about their illness or fear of treatment. On the right side, I have like a chart of the normal sleep architecture, which we all are well versed of. We all know there are cycles of alternating non-REM and REM sleep, which last about 90 to 120 minutes. There are about 4 to 5 cycles every sleep session that happen normally. And REM sleep is predominant in the second half of sleep, while non-REM predominates in the first half of sleep. The non-REM sleep has different phases, N1 through N4, and N3 and N4 are also called slow wave sleep phases, while the N1 and N2 are more superficial or light sleep stages. So this is a complicated looking table. It essentially shows various neurotransmitter system and its effect on the sleep architecture. And a lot is still unknown about how these substrates really modulate the sleep cycle, but a little bit is known about the sleep architecture. So we're going to touch upon a few important aspects. One that I would like to start with is the GABA A activation, which we know barbiturates is an agonist, benzodiazepines are positive allosteric modulators of GABA A. And GABA A is good for sleep in the sense that it decreases the sleep latency, so it makes you fall asleep faster. It increases the total length of sleep and increases N2, which is the light phase. But the dangerous thing with them are it does so at the expense of N3, which is a slow wave sleep, and REM, which are both very important, as you will see later on. And then jumping forward to the last two columns there, the orexin receptor 1 and 2 antagonism and the melatonin receptor agonism. So what the orexin receptor antagonism does is it actually is pretty good because it increases all the phases of sleep, starting from N1 through N3, and also REM sleep. It also decreases sleep latency, so that's pretty good. Essentially, if you look at it carefully, it kind of replicates normal sleep architecture. And what melatonin receptor 1 agonism does is that it doesn't have much of an effect on slow wave sleep or REM. It increases the total sleep time somewhat and increases N2, which is light sleep. But what we know for sure is that it shifts the circadian rhythm rather than having actual changes on the sleep architecture itself. Okay, so talking a little bit more about the orexin system. Orexin is a peptide that gets secreted in the brain in response to emotionally charged stimuli like feeding opportunities or reward opportunities or threats. And it promotes alertness and wakefulness. It gets secreted as a pre-peptide or a pre-protein, gets cleaved into orexin A and B, which ultimately stimulate orexin receptor 1 and 2. And this slide is, again, a little bit busy, but this just shows the projections of where this orexin goes and its downstream effects. So orexin promotes wakefulness through all these other neurotransmitter systems, like norepinephrine via stimulation of locus coeruleus, dopamine via stimulation of ventral tegmental area, serotonin via stimulation of dorsal raphe nuclei, and so on and so forth. But the main job of orexin is to stimulate all these other neurotransmitters which promote wakefulness, and thus it has an overall net effect on promoting wakefulness via all these. Importantly, it inhibits the ventrolateral preoptic nucleus, which is the main sleep center in the brain, which lies in the hypothalamus. Now, moving on to the melatonin system, quite frankly, we don't know a lot about what melatonin does, but what we know is that it the onset of melatonin secretion happens by a stimulus which we call dim light melatonin onset, DLMO. So whenever there's a dark phase or the lighting gets dim during the day, it leads to decreased activation, decreased stimulus on the suprachiasmatic nucleus in the hypothalamus. This suprachiasmatic nucleus is kind of the main circadian rhythm center in the brain. And once its activation decreases, it leads to disinhibition of melatonin release from the pineal gland. And then melatonin stimulates its receptors, and which are expressed in various different sleep and wakefulness centers in the brain. It's out of the scope of this discussion to speak about all those downstream effects. But what we know from some preclinical studies is that melatonin 1 receptor might potentially increase REM, and melatonin 2 receptors actually might potentially increase non-REM sleep. But this is preclinical data. It has not been proven in humans yet. So melatonin, as I was saying in the previous slide, remains a mystery. What we know is that and what we've known for years is that it acts as a switch to reset the sleep and circadian rhythm of the body. This is what we call sleep process C, C standing for circadian. But we do not know how sleep or how melatonin acts on sleep homeostasis, which is the sleep process S, which essentially means that there are processes that activate while we are wakeful, which eventually build up in our system and put pressure on sleep. So they kind of induce sleep after a period of wakefulness. That's what sleep homeostasis is. And we don't know how melatonin really acts on that. And we also do not really know how melatonin acts on or changes the sleep architecture. So, so delirium, and we all know that circadian rhythm disturbances is one of the main attributes of delirium. What we see with delirium is our disturbances in normal physiological sleep architecture. And what they've studied is that it severely fragments the sleep-wake cycle, reduces the total sleep time. It increases superficial kind of sleep, N1 stage of non-REM, but it severely decreases the slow wave sleep as well as the REM sleep. And we'll discuss why this is important. Talking about sleep disturbances in delirium is important because 97% of patients with delirium experience sleep, wake, and circadian rhythm disruptions. But this is not a one-way street. Sleep and circadian disruptions also actually can predispose one to delirium via various mechanisms, but the main ones are that whenever the circadian rhythm gets disrupted, the melatonin in the body reduces, which leads to more aggregation of amyloid and hyperphosphorylation of tau. It also induces the immune cells to have a pro-inflammatory response. It also increases nighttime cortisol levels and sympathetic activity, again, all leading to neuroinflammation and increased oxidative stress. So all this can together predispose a patient to delirium. So which comes first, circadian disruptions or delirium? Nobody knows, and we do not know for sure. There is likely a common pathophysiological pathway which links the two. But the key message from this is that delirium not just needs to be treated, it needs to be prevented, more likely in hospitalized patients. Because delirium has a lot of negative impact on patient care. Studies have shown that the cost of treatment of a delirious patient can be up to 2.5 times that of a non-delirious patient in the hospital. And it can also have profound long-term impacts on cognition of patients once they experience delirium. So now talking about the article that I'm going to discuss, it is titled Preventive Effects of Remeltion, Suvorexant, and Lemborexant on Delirium in Hospitalized Patients with Physical Disease. It's a retrospective cohort study, which was published in the Journal of Clinical Psychopharmacology in July 2024. And it's a Japanese study. All the investigators are based in Japan. The objectives that they came up with for this particular study was to kind of look at and all-cause incidence of delirium in adult patients admitted to medical and surgical units for non-psychiatric reasons. They also assessed the risk factors associated with the development of delirium. And ultimately, and most importantly, they studied and compared the effects of benzodiazepines, Z drugs, Ramelteon, suvorexant, and lemborexant on the development of delirium. It's a retrospective cohort study, and this cohort was studied over patients recruited over 2 years. And these patients were patients with whom a psychiatry CL team was consulted to treat insomnia. So the inclusion criteria is patients were admitted to medical surgical units for non-psychiatric reasons. Psychiatry was consulted for insomnia in the context of having risk factors for delirium, such as old age, dementia, or previous history of delirium. Of note, patients did not meet the criteria for delirium when psychiatry was consulted. Patients who were excluded were those with neurobehavioral symptoms of dementia or disturbances of dementia. Again, the diagnosis of dementia itself was not excluded, but just disturbances of behavior with dementia was excluded. Current antipsychotic use and disturbances of consciousness like encephalopathy was excluded. Less than a week duration of admission and sporadic use of sleep-inducing medications were also excluded. Significantly, trazodone use was not, patients with trazodone use were not excluded. They were actually kept a part of the study. So they assessed a lot of factors. They hypothesized that this list of factors would likely be predisposing towards delirium, which includes age, sex, dementia, electrolyte imbalance, chronic alcoholism, and more importantly, use of benzodiazepines, Z drugs, and other deliriogenic medications were studied. And then they hypothesized, on the other hand, that Ramelteon, suvorexant, and lemborexant might be protective against delirium. The primary endpoint that they were studying was the development of delirium. So the way they planned to analyze this data was to have the continuous variable, which is the age, and all the other categorical variables that I mentioned in the previous slide, and put them through a multivariate logistic regression analysis to arrive at the primary outcome. They were going to divide the outcome into patients with delirium and patients without delirium, and then compare and contrast all the factors leading to that outcome separately, while controlling for the rest of the factors using the logistic regression. So coming to the results, the table on the left shows patient characteristics. What I found interesting is that the median age of patients was 75, which is quite a significantly elderly population that they really studied. And then and I see that post-operative patients are about 50% in the study, which shows that there's a good balance of operative and non-operative patients. 30% patients received Ramelteon, suvorexant, lemborexant each, which is a well-balanced number for all these medications. And benzodiazepines and Z drugs were administered to about 20% of the patients. And also the rest of the table gives me a good idea that it was a good mix of pathologies that the patients were admitted for. So coming on to the primary outcome, 710 total patients were assessed in this study. And out of those, 36% patients developed delirium, and the rest of the patients did not develop delirium. So jumping on to the most important finding in the results. So going down the list, age, we can see, was a significant factor in causing delirium. The higher the age, the higher the odds of developing delirium. And by the way, I forgot to mention, they presented their results in the form of adjusted odds ratio. So all of these outcomes have an odds ratio, which you can see here on this chart. So age was significantly associated with delirium. Surprisingly, female sex it's not a statistical significance, but there's definitely a significant trend of female sex being protective against delirium. I definitely find this interesting and do think that this needs to be studied more about why that is the case. And the other ones are obvious. Electrolyte imbalance causes delirium. And so going towards the medications that we were studying. So talking about Ramelteon and Z drugs together, both of them were not found to significantly either cause delirium or prevent delirium. They were not significantly associated with delirium at all. Benzodiazepines, as one would expect, was caused delirium significantly more than just by chance. And suvorexant and lemborexant, both of them were protective for delirium. And surprisingly, lemborexant seems to have a much stronger effect in preventing delirium than suvorexant above it. So what we looked at in the results is kind of discussed here. Suvorexant, which is a dual orexin receptor antagonist, which just means that it antagonizes both the receptors of orexin, was significantly effective in preventing delirium. This is not a novel finding. This is a replication of previous meta-analyses that I've mentioned here. And also more recently, a JAMA RCT was published with old patients, which also shows a similar trend of suvorexant being protective. A good finding here in this study was that suvorexant does not increase the REM sleep in healthy individuals, but it does so in individuals with sleep deprivation, like patients with insomnia, sleep apnea, COPD. Lemborexant was more impressive in its prevention of delirium in this particular cohort study and they hypothesized that the reason for that is because it increases both non-REM sleep and REM sleep, as opposed to increasing only REM sleep with suvorexant. Previous retrospective cohort studies have also shown similar findings for lemborexant, and I've listed them here. Those were studied in intubated patients and ICU patients. But we do not have a meta-analysis like we do for suvorexant, for lemborexant. Ramelteon and Z drugs did not show any specific association with delirium. But this is a little bit in contrast with previous studies which show that zolpidem actually can potentially reduce REM sleep and induce delirium. So this needs to be explored further, why there's a distinction between this study and zolpidem specifically in the past. And benzodiazepines, as has been universally accepted, worsens delirium, should never be used for hospitalized patients for insomnia. So some of the things that I liked about this paper is that it is a one of its kind paper, the first original paper to talk about comparing multiple different novel sleep-inducing medications. They've compared 2 DORAs and 1 melatonergic agonist agent. And also, it talks about an all-cause cohort of patients. It does not restrict itself to only high-risk cohorts like older patients or ICU patients or post-operative patients, something which we have seen in older studies. So discussing a little bit more about the DORAs, it has a positive effect on sleep induction and maintenance. It does not give you any characteristic side effects that you see with sedatives like tolerance, rebound insomnia, withdrawal effects. It most importantly maintains physiological sleep architecture. That is to say, it maintains non-REM to REM sleep ratio, which is very important, as we have already seen that in delirium, both non-REM and REM sleep are disrupted. You can see in this table here that both of them are metabolized by CYP3A4, and so caution needs to be exercised while co-prescribing them with other medications. Half-life for suvorexant is 12 hours, and the effective half-life of lemborexant might be around 17 to 19 hours. Just to say that lemborexant might have more daytime side effects like daytime sedation or even cataplexy. That's something that we worry about with orexin antagonists. And it is safe to use for patients with COPD, obstructive sleep apnea, renal impairments, and mild to moderate hepatic impairment. The dual melatonin receptor agonist that we discussed, Ramelteon, is a non-selective agonist at both melatonin 1 and 2. It is also metabolized primarily by CYP1A2, but also by CYP3A4, and one needs to practice caution. None of the classical side effects have been reported yet. The effect it has on sleep is less subtle. It reduces sleep onset latency. It increases total sleep time somewhat, but it does not does not affect the sleep architecture classically. And most recently, I found a systematic review and meta-analysis of 5 RCTs in 2023, and they found that Remeltion did not prevent delirium, which is consistent with what we found in our study as well, this present study. So this is a good summary of what the findings were. Here you can see that benzodiazepine kind of has a similar effect on sleep architecture as that of a delirium. While Remeltion while suvorexant and lemborexant has opposite effects. Both of them increase REM sleep, and lemborexant even increases the slow wave sleep. So both of them kind of reinstate or restore the normal physiological sleep architecture. At the same time, Remeltion and Z drugs do not affect the REM significantly, neither do they affect the slow wave sleep. And therefore, we see that I hypothesized by the findings of this study and others that REM sleep and slow wave sleep might be key in preventing delirium as compared to improving just REM sleep. And I also found that lemborexant is more selective for orexin 2 than orexin 1. And this suggests that orexin 2 antagonism might have a more profound effect on sleep continuity than just orexin 1 or orexin 1 receptor. There are several limitations of the study, and the major one is in its study design. It's a retrospective observational cohort study. So there's no way that the findings, there could be any blinding or randomization of treatment in this study, which is a big limitation. Also, these patients were diagnosed retrospectively using the DSM-5 criteria for delirium. While the patients were actually hospitalized, delirium tools like CAM-ICU were not actually used to diagnose them. As I was saying earlier, the median patient age is 75, which makes it difficult to generalize the findings to all age groups. Qualitative and quantitative sleep assessments were not performed, so they don't actually know the impact on sleep architecture in a more profound way. Trazodone was not considered a factor in the analysis. Individual drugs within benzodiazepines and Z drugs were not distinguished as risk factors. And it might be especially important to talk about zolpidem separately because it has shown to worsen delirium. Dose and duration of sleep-inducing medications were also not assessed, so differential effects of different doses or duration of a patient being on these medications on the prevention of delirium or worsening of delirium. And finally, some of the well-known risk factors for delirium, like opioid use, ICU stay, disease severity, and polypharmacy were not taken into account as well due to lack of consistency in assessing them. So coming on to the most important slide and the last slide on this journal club presentation is implications or the take to hospital message that we have. The most important that I thought was early action needs to be taken to treat hospital insomnia. We do not get many consults just to treat insomnia, which I'm very thankful about, but I do think that these needs to be addressed and education needs to be increased amongst our peers. If one has to treat insomnia in the hospital, suvorexant and lemborexant do seem to be effective treatment in not just preventing, but also presumably reversing delirium because, as I mentioned, its impact on reinstating the physiological sleep architecture it has pretty solid evidence now. Remeltion, not so much, so it might not be helpful in preventing or reversing delirium. As we know, best to avoid GABA agonists or positive allosteric modulators because they just worsen delirium, and it's not a good idea to ever use them for sleep in the hospital. And if DORAs are unavailable, which is recent news at Norton Hospital, we can use 5-HT2A antagonists like olanzapine and trazodone because they usually do not disrupt the sleep architecture and actually are have been found to restore slow wave sleep as well. And then, of course, non-pharmacological methods are king in preventing or treating insomnia. And we all know what those are, so I'm not gonna belabor the point, but that's it from my presentation. These are the articles that I looked at for making this journal club presentation. Thank you.
Excellent job, Dr. Shah. Let's see, any questions in the chat? You can raise your hand.
I think there are no questions, which means that everybody's gonna advocate for getting Belsomra back to Norton Hospital.
It means you did a thorough presentation. Yeah. All right.
Oh, Jack, I think.
Hey, sorry, that was my question. I know that like Belsomra is only available at a few places. I didn't know if we had like Luvorexin available anywhere. And, on that note, what kind of things can we do to try to advocate for getting these into some places? Because it seems like the evidence is pretty consistent that this does a really good job. And obviously there's a lot of, costs associated with delirium. It's really bad for patients. We all know that. But what can we do to try to keep this conversation going?
That's an excellent question. We do, I think, I worked with I worked with Dr. Oliva last month at Norton Hospital, and we were in conversation towards the end of our time together that we should reach out to the pharmacy and kind of advocate for this. I know we have a lot of attendings in our program that really like the medication based on good evidence. I do not know the exact ways how we can like reach out to pharmacy and make sure that we like send a strong message that this is important and needs to be in formulary. But yeah, that's a good question. We definitely need to get together and discuss it more.
There's some other questions now, Dr. Shah.
Dr. Summers is up next. Dr. Summers, did you have a comment or a question?
It looks like she might have gotten disconnected.
All right. Dr. Arpagiev is up next, I think. And
Well,
then
the question before was what I was originally going to ask, but I guess I just add on to that. It would, I guess I would wonder if someone would be interested in doing like a quality improvement study, and there could be opportunities through U of L because they do have a quality improvement like group or whatever, but looking at the cost savings and looking at, how much like you mentioned the cost difference between patients who have delirium versus not. And, does there need to be something more proactive in like, admission orders with, ordering sleep medications and, inquiring in our check-ins about sleep quality more uniformly?
Yeah, that's definitely a good idea. And you make an excellent point, Dr. Ravijiev. Like, also, we do have kind of, so we do have a requirement at least U of L when I last worked at the consul service that one has to fail like 3 treatments with different sleep medications. But we just don't have all those different options, all those different good options that might prevent delirium before we go on to Suvorexant. So I think we do need to use this more often. And once we start using this more often, a quality improvement uh, study should definitely take place. And another important thing that they mentioned in this article itself is the cost of prescribing these medications in America is very restrictive to its use. But then we also have to take into account the cost that was saved because delirium was prevented by the use of these medications. So that's going to be a longer kind of a discussion, but needs to happen.
Dr. Reif, did you have a question?
Yeah, going based on the previous comment. So Belsomra and Dayvigo are very expensive medicines. Something that's weird about this, I guess, article is is it has both kind of prospective and retrospective aspects to it, and they eliminated some of the retro aspect or some of the aspects would make it so that you would consider these medicines over something that's cheaper, like trazodone or mirtazapine. I don't know why they excluded some drugs but didn't exclude trazodone from the results. My guess is that in the retrospective review of it, they probably performed similarly, and they didn't want to have a similar result to trazodone, which is cheap as dirt. But I don't know for sure. And then, yeah, I mean, it's just kind of weird some of the choices that they made in looking at the data.
Yeah, that's true. I might have misrepresented the study. So they did not exclude trazodone. They did not just factor it in as a risk factor for
Right. They
studying
didn't
its
factor
impact.
it as
So
a risk
you're right
factor or
about
an
that.
yeah,
That
so
might have
like
been a
they didn't
good
review trazodone on its own, but they
right.
reviewed, say, like the Z drugs or benzodiazepines on their own, which is what they should have done to make a strong argument for these newer, expensive medicines. And so without data like that, it's hard to argue to a hospital committee, hey, we need to have these medicines to prevent delirium. And then also, as a psych consult service, we're often not consulted before the patient has delirium, we're consulted after the patient has delirium, which, I mean, of
Right.
course, the study didn't review at all.
Yes, this study excluded people who were consulted for delirium, which might also be like a cultural difference between how psychiatry is practiced in America and Japan. They might be getting a lot of consults just for insomnia before delirium sets in, which we do not.
Right.
But
Like
that's a
good
good point with like maybe using trazodone and other 5-HT2A antagonists like atypical antipsychotics for sleep before moving on to like ordering Belsomra.
or at least getting good data suggests that these drugs are more or superior to trazodone or cheaper drugs to prevent delirium.
Yeah, that's an excellent point.
All right, great discussion, everyone. Thank you again, Dr. Shah, and we will move on to last but not least, our final presenter, Dr. Elsayed.
Hello, can you hear me?
Yes.
Okay. Hi. Thank you so much for joining us for this talk. For those of you who do not know me, my name is Omar Elsayed. I'm also a second-year resident. Glad to be here. Today, I'll be talking about MDMA-assisted therapy for moderate to severe PTSD. I'm going to explore some of the evidence that we have so far. We're going to talk specifically about one of the phase 3 trials that were a part of the FDA application to get this approved. And we're going to highlight the FDA decision. I think that's probably where the angle that we're going to, explore this through. Unfortunately, I still don't have any disclosures to share, but, open for suggestions. So for today's talk, really, I would like to classify it into like 4 sections. I want to talk about psychedelics and psychiatry in general. Want to, discuss the article in question, and then we'll highlight the controversy and FDA decision and make our own conclusions. So this is a quote that I came across. It's from a 19th century UK biologist, and I think it kind of encapsulates sort of what the problem with this study was. Okay, so what are psychedelics, right? I would like to briefly discuss psychedelics and psychiatry in general. I'm not going to go into too much details, really. This has been explored extensively with a lot of my colleagues, and I would specifically like to shout out Dr. Pawa's last year journal review. She did a great job in one of the articles, like sort of took an overlook on psychedelics from a scientific and historical standpoint in general. But we'll just put in some highlights, right? So what are psychedelics? They're a class of psychoactive substances that alter perception, mood, and cognitive processes. They can also cause profound changes in consciousness. They have been described as causing visual and auditory hallucinations. They tend to distort your sense of time, and some people have described a deep emotional and spiritual experience when they dabble into psychedelics, right? So naturally occurring psychedelics have existed for millennia. They have a long and rich history in culture in general, tribal use and like spiritual experiences. I'm not going to really dive into that. I think I want to focus more on the synthetic hallucinogens that came up to be within the last century or so, right? So Albert Hofmann, Swiss scientist, he worked for a company called Sandoz. He was the first to synthesize LSD specifically, or lysergic acid dithylamide. It's the first known psychedelic, synthetic psychedelic. And he kind of had a very famous inadvertent experience with the substance that he ingested. You guys can look into it. I think it's quite interesting, but it's basically the first described trip in history, right? So he described it as an uninterrupted stream of fantastic pictures, extraordinary shapes, with intense kaleidoscopic play of colors. Very, very early on, like at 1947, LSD was used as an adjunct for psychotherapy. That was not supervised. That was not really evidence-based, but it was something that kind of like they jumped into right away. And then in the 1960s, a very notorious psychologist, PhD, his name is Timothy Leary, quite notorious actually. He led the Harvard psilocybin project into looking into some evidence, exploring sort of using psychedelic psilocybin in particular as an adjunct to therapy. Now, Thomas Leary was a controversial fellow. He dabbled into psychedelics a lot. And he was expelled from Harvard in 1963. I think there was a lot of controversy surrounding his experiments, some ethical problems, and it's kind of been sort of questioned. The Concord experience for any of you guys who would be interested in learning more about it. But yeah, so they were fired. Timothy Leary and his colleagues who worked on this project were fired from Harvard in 1963. At the same time, LSD ran out of patent from Sandoz and became a lot more popular, started being used in a medically unsupervised setting. In 1965, this sort of prompted the government, especially in Europe and the US, to pass laws to kind of like strict the use of LSD. So in 1965, the Drug Abuse Control Amendment was passed, and it basically, delegitimized the use of LSD and required anyone who had LSD in their possession to sort of give it up and relinquish their supplies. This kind of got a little more confounded. Around 1970, there's a Controlled Substance Act that put psychedelics as illegal drugs. And this was exacerbated by Nixon's infamous war on drugs in general. And this sort of pushed the psychedelics into the counterculture rather than being up forefront. Halted research, and research on psychedelic use for psychotherapy was halted for quite a while, up until the mid-1980s or so. A bunch of companies started experimenting with psychedelics again. Of particular interest for us is MAPS. MAPS is called the Multidisciplinary Association for Psychiatric Studies. It was founded in 1986, and it was later rebranded, or really like a subsidiary of it was rebranded to Lykos. So Lykos is the company that's actually sponsoring this particular study, right? Over the years, around 2017 and 2018, the FDA did give sort of exceptional designation or breakthrough therapy to a couple of these companies to look into PTSD and treatment-resistant depression. As we'll come to talk about it in greater detail, eventually kind of rejected one of those applications. Microdosing was a trend that took over. It doesn't have really any scientific evidence just yet, but that's one of the things that is kind of taken over. And really, the resurgence of psychedelic therapy has been marred by a lot of controversy and has polarized the psychiatric field at large. Even Albert Hofmann, the virtual inventor of these substances, has later kind of expressed some skepticism in his autobiography around 1979 before he died. So these are the major compounds, some of the examples that are considered like psychedelics. We're particularly interested in MDMA for the purposes of this review. So what is MDMA? It's an altered methyl, so it's a 3 and a 4 methyl inidoxy methamphetamine ring. Okay, so it's a sort of an analog of phenylthylamine, and it has some structural similarities to amphetamines and mescaline at the same time. Interestingly, the first time MDMA was invented was in 1912. They really tried to use it as a substance to stop hemorrhage, but it wasn't really very effective for that purpose. 1976, Alexander Shulgin resynthesized it and discovered its psychedelic properties. And as soon as it, sort of like it was discovered as a psychedelic, and despite lack of systematic research, psychotherapists tried to use it as an adjunct for therapy in general. And they, basically think that they enhanced their patients' insights and understanding, and it was mostly psychoanalytical kind of perspective of using MDMA. And then in the 80s, MDMA sort of redistributed on what we call on the streets, and you guys might be familiar with it as ecstasy. It was a very popular dance, party drug, very popular in raves. And because of this, the DEA eventually kind of banned it in 1985, placed it as Schedule I substance, and permanently in 1988. And then we talked about the breakthrough designation by the FDA. They were working with Lykos in particular to design trials to see if they may be effective for the treatment of PTSD therapy. And eventually in 2024, the FDA rejected it as of now, but there's like potential possibilities. We'll explore all of this very quickly. So what is the mechanism of action? MDMA is considered what we call an entactogen. It means that it has pharmacological similarities to both stimulants and serotonergic hallucinogens, or the psychedelics that we know otherwise. It is mediated by a ton of mechanisms of actions, right? So it has a lot of similarities with serotonin, with the psychedelics and with the stimulants as well. Not gonna go into a whole lot of details in the interest of time. MDMA in healthy volunteers, they produce altered consciousness, they produce euphoria, they cause a lot of empathy is what's been described, general well-being. People say they're more insightful, they're more extravagant, extroverted, they have a generally more positive mood, but they also have expressed some anxiety when using MDMA. When you compare MDMA to other psychedelics, it actually has a much lower incidence of causing hallucinations in general, whether visual or auditory. So what research do we have so far? Starting in 1994, all of the research is led by Lykos. Started in 1994, really a couple of phase 1 studies were started. There was an fMRI study on non-participants, and the only neuroscientific sort of evidence that I found is that it decreased the amygdala reactivity to angry faces, but not to fearful faces. In 2010, they started the phase 2 studies, Mithofer and others, on 23 subjects for the treatment of PTSD. They did follow up these patients long-term, sort of to see how they did otherwise. And there was a bunch of RCTs that were done in the interim until 2017 when they got that FDA designation. Eventually, 2 phase 3 trials were approved that were concluded, and we're gonna look into one of those in particular. Evidence for abuse is not present in human studies, but there's been evidence of abuse in animal studies. Okay? So move on to the article in question. And this article is published in Nature Medicine by Mitchell and others, published in September of 23, right? And it's the second of the 2 pivotal phase 3 studies that were conducted by Lykos in order to get FDA approval for treatment for use of MDMA for therapy for PTSD. This is the second of the trials, and it's a confirmatory phase 3 trial. And I chose this in particular because it has a more diverse population, and it also included the moderate and severe PTSD with very, very similar results to the first phase 3 trial that was conducted or published in 2021, also in Nature Medicine. PTSD, as you guys may know, is classified as a severe mental illness. It affects up to 5% of the US population each year. often accompanied by comorbidities, usually mood disorders, some alcohol use, and that really does complicate treatment, right? As of now, gold standard is trauma-focused psychotherapy, but it has very low retention rates, and people don't really follow through. Therapies up to 60% don't really follow through in many studies. Sertraline and paroxetine are the only two pharmacological agents that have been FDA approved for PTSD, but the effect size is not very impressive for either of those. So coming to the study design, it's a double-blinded RCT, 13 sites, most of which were in the US, 11 of which were in the US, and 2 were in Israel. It was a randomized control trial. People were randomized in one-to-one blinded fashion, supposedly, to either receive MDMA and treatment or therapy, or receive placebo and therapy. Each participant had 2 therapists, to talk to at the same time, 1 male and 1 female. This is going to be important in a second. They were assessed by off-site central assessors, and each participant was seen by each assessor only once through the study. The study was over a period of 3 months. Each of these months, like the experimental phase of the study was, each month they were dosed for 8 hours with MDMA, quite a high dose of MDMA based on the phase 2 studies, actually, 120 to 180 milligrams. And then during the rest of the month, they received therapy. The main outcome scale was the CAPS scale, or the clinician administered PTSD scale, based on the DSM-5 and the Sheehan disability scale. These are some of the major inclusion-exclusion criteria of the trial. I don't really want to go into too much details of these, but I'll highlight a couple of things that I think are most relevant to this talk. Severity score per the CAPS is 28, which indicates moderate PTSD. This is high. This is lower than the previous study that they looked into. And they excluded quite a few medical comorbidities. I think these exclusions are mostly related to the cardiovascular effects of the sympathomimetic effect of MDMA. I do want to spend a second here on the alcohol and the substance use stipulation. They did allow mild to moderate alcohol use, but they did not allow severe alcohol use. They did not allow any other substance use other than cannabis and alcohol. And they allowed people who have had experience with MDMA, which is going to come up soon, as long as it's less than 10 times within the last 10 years and none within the last 6 months. Demographics are presented here. 324 participants were screened. 53 went into treatment group and 51 into placebo group. Just note that almost all of the treatment group finished the study, whereas 9 participants did drop out of the treatment group at the end of the study. These are the demographics. They're quite comparable across treatment groups. Just a couple of things to highlight, really. Fairly young age of participants, an average 39. Female predominance, 71%, which I found to be a little bit surprising to me. They did highlight a lot the heterogeneity, the ethnic heterogeneity of the participants in the study. You'll see a lot of ethnicities in there. But most importantly to me, if you look at the number of people who have had prior MDMA use, you'll see a significant proportion of those in the study. Almost, 45% of all of the participants have had experience with MDMA in the past. And a third of them almost had experience within the last 10 years. These are the outcomes. Significant separation by session 2 in both the CAPS score and the Sheehan disability score. Let's look into the numbers real quick. The CAPS score decreased by an average of 24 points compared to 15 points in placebo group. Very statistically significant. The effect size is 0.7. But I want you guys to notice that the effect size for the placebo group is 1.25, right? So placebo was very significant. Placebo response was very significant. The score had a significant p-value and an effect size of 0.4. And these are the major marketing numbers. 86.5% of the people in the treatment group were considered responders, which is defined as more than 10-point change in the CAP score. And 71% of the treatment group completely no longer met criteria for PTSD, which is quite significant, actually. The covariate sub-analysis revealed similarities across all sorts of variables. The only variable that it wasn't really in line with was the use of SRI in the past, and they acknowledged it in the paper, but they didn't really explore it further. Now, the last point is the most important point that I want to highlight, really. At the end of the study, they gave all of the participants a blinded survey, and they asked them what did they think, which group they were in. And that 75% or 3/4 of the participants in the placebo group correctly identified that they were in the placebo, and almost all of the people in the treatment group correctly identified they were in treatment group. This is very important, right? So there's essentially functional unblinding that happened here. Now, most of the people in the treatment group really didn't have any negative things to say about it, but they said they had a positive experience, but just note that. Safety data, almost all of the participants experienced some sort of adverse event. This is both in the placebo group as well as the treatment group. And 5 participants in the treatment groups compared to 2 in the placebo group expressed severe adverse events, none expressed serious. The most frequently reported were muscle tightness, nausea, decreased appetite, and hyperhidrosis. Majority of participants, it's not really expressed in this table, but around 83% of the treatment group and 72% of the placebo group had some sort of psychiatric adverse events, and all of the severe adverse events were psychiatric in nature. So, for the treatment group, they had flashbacks, grief reactions, and dissociations, and for the placebo group, they had anxiety and agitation. So what points did they highlight in the study? They said it's replicable to all of the studies they had in the past, including the phase 2 studies and the other phase 3 study. They noted that there's no site-to-site variability. They really liked the fact that there was not a whole lot of dropouts that happened in MDMA, because that's important, right? Because people with PTSD historically do not follow through with prolonged exposure therapy. Up to 50% really drop out in the middle, whereas in this particular study, almost all of them finished it. They did note that we don't have long-term studies, but for this particular from the phase 2 studies, we know that the change in CAPS scores did stick. They did note the fact that they have a much bigger effect size than what the SRIs do. And they noted that there's a lot of complicated, interactions between SRIs and MDMA, but they didn't want to really dive into those. So what happened next? What is controversy all about? FDA, despite being a part of the design of the whole study, met in June of 2024. The advisory committee did, and they overwhelmingly rejected the studies in this particular case, with some concerns that we're going to go into. And then this was followed by the declination of the FDA to approve the treatment in August of 2024. The FDA's concerns were lack of records and information on the safety of the trials, especially the cardiovascular side effects. They said that they did not explore them well enough. They also commented on the fact that there was essentially functional unbias, functional unblinding that did happen, and the majority of the patients were able to identify which treatment group they were in. They also said that the FDA doesn't really regulate therapy, and it's hard to find out through the study how important was therapy is compared to how important the MDMA was. There was also a ton of reports that came out of ethical misconduct. This happened in this study and in prior studies as well. In this study, the reports did cite very strong prior beliefs among the therapists, the investigators, and the patients that may have influenced the results. They alleged that the therapists have made the people who participate to sort of encourage them to have a more positive outlook and to underreport self-harm in general. And they also mentioned that there's probably a whole lot of bias because people, and I understand that, people who participate in this study in any capacity probably have preconceived notions about psychedelics, maybe more positive than the general population. And that was another concern that the FDA kind of cited. Lycos did issue a sort of a detailed response declining all of these claims and rejecting them. And obviously, like this FDA decision was disappointing to a whole lot of people, but I think it's good that they sort of upheld some scientific rigor in there, right? So where do we go from here? So they declined to approve the trial, right? They declined to approve NDMA treatment for PTSD, but they said that they're okay with doing another phase 3 trials if addressing these concerns, and they might consider approval in the future. Despite Lykos' best effort, they sat with the FDA. They tried to get them to change their opinion, but that didn't happen. But the FDA is going to be heavily involved in the next phase 3 trials. And I looked into Lykos' website, and it looks like they are looking into designing another phase 3 trial. It remains to be seen whether they're going to do that or not. I think, to me, the biggest challenge would be to come up with an active placebo, right? So the placebo in this trial was passive. It means that, it didn't really do much. But, you take ecstasy, you get some effect, right? So in order to get a better placebo, in the past, we used niacin, which mimics some of the physiological effects, but it doesn't really mimic, it still doesn't have any psychoactive effect or anything like that. A typical ideal placebo would be psychoactive, would be physiologically has the same effects of a sympathomimetic, would have a compatible onset or duration of action, would be safe, but does not address the underlying issue, in this case, PTSD, right? So that will be the biggest challenge, I think, to sort of figure out a way how to blind the patients. Psychedelics are not really going anywhere. This is just like, I guess, a hump in the road, and we'll see where we go from here. So what are our take-home messages? I would say the road to hell is paved with good intentions. The fact that the evidence is quite strong for NDMA for treatment of PTSD doesn't negate the need for process. Process in science is just as important as the strength of data, in my opinion. The primary data is very strong, but we still need high quality and unbiased and reproducible trials in the future. Trial design matters a lot, and hopefully the FDA's involvement in the getting these trials on board might be beneficial for the future. I think moving forward, there's going to be a lot of scrutiny on therapist behaviors. There's going to be more training and oversight and accountability in general. Companies and obviously need to explore and take in mind the side effects and take it more seriously, and sort of like explore what cardiovascular concerns might be, especially in psychiatry, when we don't really consider it's life-saving, although it sometimes can be life-saving. I think the decision generally reflects a higher bar for psychedelic therapies and generally for substance abuse to sort of clear in the regulatory process. And I think that's also kind of fair because these drugs do have a lot of complex effects. They have a lot of legal history, and they have an important public perception aspect to it all. So there's definitely a little bit of a political aspect to all of this. The door is not closed, more work to be done, and I guess we're going to be seeing in the future what these trials do bring us next. There's a lot in the pipeline right now, exploring all sorts of things using psychedelics. These are my references. Thank you guys so much for your attention and for your time.
Thank you, Dr. Elsayed. I believe Dr. Casey is here and has a question.
Yes, thank you. Great topic. I followed this story pretty closely, and the issues that have been raised here were a surprise to the psychedelic research community who believed this would sail through the FDA. And when it did not, it was a surprise and has caused a lot of soul searching in the entire field. I think there's a subtext to this. I think that the FDA has become somewhat concerned about selection bias amongst patients and about a kind of religiosity among researchers. That is, people that are to some extent proselytizing rather than being objective about this, and also several cases of pretty egregious misconduct amongst researchers engaging in personal relationships or sexual relationships with their research subjects. But there's another aspect of this. When there was a public comment opportunity, there were a number of individuals with some interest in this topic who testified against, unexpectedly testified in person against the approval of MDMA. And it turned out there was an expose in the New York Times that was published later that this was actually an organized group. And their concern really was not approval of MDMA. This was a sort of a group that is an anti-commercial group. They did not believe in the commercialization of psychedelics. That was really their concern. And so the FDA has gotten a lot of scrutiny from both sides about whether they should or should not have approved this. But I think that some of the issues that have been raised here may be of concern, especially in psilocybin research, which may have some of the same issues. So I don't think we've heard the end of this. I think that MDA isn't going to go away, particularly veterans groups that are very interested in PTSD and don't see a lot of other good alternatives are still pretty excited about this, and we may yet see this reemerge.
Yeah, thank you very much, Dr. Casey, for this, very insightful comments. Yeah, I think definitely the political aspect to all of this is quite interesting. Obviously, science has always had a very complicated relationship with policymakers. The way that we use some of the information can, be skewed one way or another, and yeah, I think it's quite interesting. And I'm very excited to see what's going to happen next.
All right, everyone, we are out of time. Fantastic job.